Buenas tardes, bienvenidos al seminario web titulado Neuropsychological Evaluation for the Inborn Errors of Metabolism, The Need for a Unique Perspective, dictado por la doctora Susan Waisbren. Esta instancia ha sido organizada por la Sociedad Latinoamericana de Errores Innatos del Metabolismo y Pesquisa Neonatal y el Laboratorio de Enfermedades Metabólicas del Instituto de Nutrición y Tecnología de los Alimentos de la Universidad de Chile. La conferencia será realizada en inglés y durará entre 30 a 40 minutos. Luego tendremos unos minutos para resolver sus dudas, por lo cual los invitamos a realizar sus preguntas mediante la opción Pregunta y Respuesta de la plataforma Zoom o a través del Facebook de SLEIMPN o de INTA. Además, que las preguntas las realicen mediante avanza la charla y no al final para que éstas puedan ser respondidas por la invitada. Este seminario estará moderado por el doctor Juan Francisco Cabello, quien es médico cirujano con especialidad en neuropediatría, profesor adjunto de la Universidad de Chile y profesor instructor de la Universidad de Valparaíso. Fue presidente de SLEIMPN en el periodo 2013-2015 y actualmente es parte del comité científico. Doctor Cabello, puede comenzar con el seminario web.
Muchas gracias, muy buenas tardes y bienvenidos a todos. Buenas tardes en toda Latinoamérica y para quienes se conectan de otras partes del mundo también. Bueno, como dijo Florencia, hoy la presentación será en inglés, así que vamos a hacer la presentación en inglés también de la doctora Waisbren para que ella pueda entendernos también. Así que vamos a cambiar de idioma en este momento. Good afternoon, everyone, and I would like to introduce Dr. Susan Waisbren. So it's a real honor for me to do this because Dr. Waisbren has a long CV that we will try to summarize. She's a professor of psychology in the Department of Pediatrics at Harvard Medical School and Boston Children's Hospital in Boston, Massachusetts. After receiving her undergraduate degree at Yale University in New Haven, Connecticut, she received a PhD in clinical psychology at the University of California in Berkeley. During her 40 years career at Boston Children's Hospital, she provided leadership in psychology and developed multiple innovation for the metabolism and genetic programs. She evaluated and consulted patients with PKU and other metabolic disorders from infancy through adulthood and investigated factors related to outcomes. She consulted parents in their journey caring for children with chronic, often severe health conditions. She's one of the few psychologists in the world specializing in disorders identified by neuroscreening. Early in her career, she recognized the need to study psychosocial in addition to biological factors, contributing to adherence to medical recommendations and psychological outcomes in genetic disorders. This resulted in the creation of camp programs for youth and social support programs for adults. More recently, she has participated in developing and evaluating outcome measures for clinical trials in metabolic disorders. Recently retired from clinical work, Dr. Waisbren continues to mentor younger psychologists and medical fellows and consults on psychological issues related to health conditions. She's the author of more than 100 scientific publications and is working on a series of articles about the psychological attributes of metabolic disorders. Outside her professional life, she's an extraordinary woman and mother. She has run countless marathons, proving his perseverance and hard work on the track. Above all, Susan has an inspiring personality who manages to charm patients and colleagues and drives them to work as a team. It's a tremendous honor for me to be able to present her today. I hope you enjoy her presentation. Susan, please.
Okay, well, thank you so much for the kind introduction. It's really an honor for me to be here, and I want to welcome all the participants and to especially thank the organizing committee from INTA and the Latin American Society for Inborn Errors of Metabolism. So as it says here, I'm going to be speaking today about neuropsychological evaluations for the inborn errors of metabolism, the need for a unique perspective. Next. So I want to disclose that I do consult to pharmaceutical companies about neuropsychological endpoints for clinical trials in different metabolic disorders. And there's a list of the companies, but I want to add that these companies are willing to work in very rare conditions. And for that, I'm happy to be able to participate. And I want to encourage those of you who might want to contact these companies if you have patients with these diseases to also participate in their clinical trials. It may facilitate being able to get the drugs in your clinics a little sooner. Next. So, as I said, I'll be talking about how metabolic disorders affect psychological well-being and about some ways to evaluate and help patients and families. And I understand that there's a wide range of types of patients that are seen in Latin America, some identified by newborn screening, others not. Some clinics have psychologists, others don't. Some have expanded screening. So I'll try to touch on the range of outcomes. Next. So this talk is important because deficits in neuropsychological functioning are often specific to a particular disorder. And that's why I say there needs to be a unique perspective. Psychologists need to know about the importance of metabolic factors and the specific risks depending on the diagnosis. And sometimes other healthcare providers need to evaluate the psychological functioning of their metabolic patients and provide advice. So I'll try to address that too. Next slide. So the goals of today are first to recognize the typical developmental, cognitive, and behavioral outcomes in different metabolic disorders, and then to understand the importance of a unique perspective when evaluating and counseling children and adults with these disorders. And finally, to learn about some methods that can be used by psychologists, but also by other providers for assessing neuropsychological functioning. Next slide. So the three key points to remember are first, that different metabolic disorders lead to truly different challenges in neuropsychological functioning. They're not all the same. Even if there's intellectual disability, it presents a little differently. Children and adults with metabolic disorders share the need to develop an identity beyond their metabolic disorder. In other words, we need to look at the whole person and not just their disease. And then all healthcare providers can help in screening and counseling patients. Psychologists are uniquely trained to provide more in-depth evaluations, and they are also better able to make recommendations for specific follow-up in education or counseling. Next slide. So key point number one, different metabolic disorders lead to differences in neuropsychological functioning. Just as these pictures of kids, they're all so different. Next slide. So here's the first example is PKU, and I understand that's the most common disorder identified for your countries and also in the US. But if we look at those that have a full-scale IQ less than 85, which we consider as the borderline range, that those with PKU aren't significantly different than what is seen in the general population. Now, these are treated cases, okay, and generally newborn screened cases now. Those who have a reading deficit, well within what's seen in the general population. However, they do have more trouble in arithmetic. And I think there's a sequencing issue as well as a memory being able to hold information in mind that accounts for that. Far greater number have trouble with visual, spatial, or organization or integration. They can't find their way without a GPS at all when driving. And so that, again, that's a spatial orientation problem. Executive functioning, we'll be talking about that a bit. For those who aren't familiar with that concept, executive functioning, I can usually explain as the ability to keep information in mind, to remember something, and use that information in another way for problem solving. So that includes memory, but it also includes planning, being able to see what are the steps I need to take, organization, meaning to organize the information, attention, and a number of other skills. And then on tests of behavior, they tend to have attention issues, anxiety, and depression, far more than in the general population. Interestingly, children with PKU or adults with PKU actually tend not to be hyperactive. The kids might be, but they do tend to have attention problems well into adulthood. Next slide. So this is the characteristic profile in PKU. These children tend to be active with learning difficulties, usually occurring around 4th grade, ages 9 to 10, when tasks require executive functioning. The treated cases tend to be good early readers. School problems tend to be in the areas of handwriting, arithmetic, and reading comprehension. Again, that's that memory and organization ability. They're frequently described as having ADHD, but I believe that the underlying deficit may be a slow processing speed. Anxiety is common. And back to this issue of attention deficits. Imagine a child sitting in school and the teacher gives them instructions about how to complete an assignment. So she gives the first part of the instruction, and the child with PKU struggles to process that information. He just about has it when she goes to the second step that they need to do. So he's working really hard to get in to remember that second step. By the time she gets to the third step, he's lost her, and he takes his pencil and he pokes the kid next to him. So that's really not attention deficit or hyperactivity, but really a slow processing speed. So that's something to remember when talking to children with PKU, but also when trying to figure out what might be the best way to treat them. Next. A second example is galactosemia. And what fascinates me from the very beginning about metabolic disorders is you can have a single gene defect that affects the brain in such different ways. And in galactosemia, you'll see, which has a much easier diet than PKU. They just need to avoid dairy products. They have a lower IQ. They have a far greater chance of having intellectual disabilities. IQ or DQ less than 70 is considered intellectual disabilities if there's also adaptive behavior issues. Speech delay in most studies show 80%. In my clinical work, I'd say 95% are slow in learning to talk. Though there's a new project going on right now, and there's been a few publications called Babble Boot Camp, where they're training children with galactosemia starting at age 6 months, strengthening the motor muscles in their tongue and getting core strength. And those children are not showing the speech delay. So that might show that the motor delay has a lot to do with that. Behavior problems are common in galactosemia, though not much more than in the general population. Though we do tend to see some behaviors on the autistic spectrum. Now that may have to do with the inability to communicate through language. And there's been a little bit of psychosis. Our experience has been, and we're concerned, very concerned about the adults who seem to be aging more quickly, and some of them having early dementia and memory problems. And they tend to be shy, though not more so than what people report in the general population. Next slide. So here's the characteristic profile. These children are often referred to by teachers as the nicest kids around. They do tend to be shy, quiet, and somewhat awkward in social situations, maybe because of their language. Many have a few behaviors that are associated with autistic spectrum disorder, but again, this may be related to social anxiety. They may appear less capable than they are due to slow verbal response times. And most researchers now believe that the speech problems reflect an underlying motor deficits. Adults continue to show this personality. I had a young man come see me, one of the nicest young men ever. And he was in his early 40s. And he said, I asked him why he didn't have a partner. And he said, you know, if someone got to know me, I think they would really enjoy being with me, but I'm kind of hard to get to know. So I thought that was really quite telling. Next slide. So then we go to the fatty acid oxidation disorders, the medium chain acyl-CoA dehydrogenase deficiency, or MCAD. Now remember, in this disorder, it's not so much a cognitive issue, but they can have sudden death if they get dehydrated or don't have enough to eat. So very few of them have IQs in even the borderline range. Again, we see speech delay and some motor delay. The executive functioning is fine, no problems with attention, pretty high anxiety, not really depression, but many of them tend to be quiet and somewhat introverted. The scale calls it withdrawal, but they tend to be introverted. Next slide. So here's the characteristic profile there. These children tend to be late bloomers with speech language delays or relative weaknesses in this area compared to the motor and cognitive domains. By late bloomers, what I mean is they catch up as they get older. By school age, a general shyness is noted. Many are anxious and somewhat withdrawn. They don't act out or behave aggressively. This personality style may place the children at risk due to a reluctance to admit they do not feel well or they need to eat or drink more frequently. So that's something that not even a psychologist needs to tell the families and the teachers, but any health provider can say, watch out for them if they didn't eat their lunch or if they're looking lethargic. They won't tell you, but you need to pay attention and remind them to eat. Next slide. So now we go to urea cycle disorders, and I'm going to present, I think, just two of them to show how even in the same metabolic pathway, you'll see differences. So this is argininosuccinic aciduria, or ASA. Now, these kids tend to do the worst, with many of them having low IQs, at least in the borderline or even the range of intellectual disability. Speech delay isn't as big of a problem as it is in some of the other disorders, significant motor deficits. But we see equal numbers having declines in their performance as having increases in their performance, or almost equal numbers, which is unusual. We don't see that in other diseases. And that may be because of their levels of ammonia at the time. And behavior-wise, they tend to act out. They're more the externalizing behavior rather than the withdrawn or quiet ones. Next slide. So these children tend to be at risk for developmental delay. However, there's a much wider range than we'll see in some of the other disorders, from DQ and IQ 63 to 135. Motor deficits are most common, and behaviors tend to be of the externalizing variety. Next slide. And now we go to citrullinemia, or argininosuccinate synthase deficiency, or ASD. Here we see far fewer with intellectual disabilities. In fact, for a while, people thought that wasn't an issue at all. Not much speech delay, but strong motor problems. No declines in IQ or DQ. They tend to get better, and not really any behavioral problems. So here the problem really might be more physical. They can have sudden death. Next slide. So these children tend to have normal cognitive abilities. Speech development is usually normal. Motor skills are not as well developed. And in this sample from the urea cycle disorders longitudinal study, behavior was also generally within the average range. Though in our clinic, we had a few that had severe behavioral problems, and we don't really know whether that was because of their metabolic levels or exposure to ammonia or the treatment, the need for frequent treatment. Next slide. So here's a summary, and the purpose of this summary, I'm not going to go through it all, but this will be available to you. But just to see the variability in these different disorders and how important it is for the psychologist or whoever's evaluating the child to know this. Otherwise, psychologists may treat a child with intellectual disabilities as, oh yeah, they're just low in everything, and not realize the impact of a metabolic disorder. Next slide. Or you can leave it up for a little bit so people look at it. Okay, so now we go to the second main point. Children and adults with metabolic disorders share the need to develop an identity beyond their metabolic disorder. Now, this is an important part of the unique perspective needed when evaluating and counseling children and adults with metabolic disorders. The impact of frequent hospitalizations, the impact of having a parent always monitoring what you're eating, having frequent blood tests, the anxiety that parents may feel if you have a urea cycle disorder, for example, can have an impact. And so there's a real need to look at the whole person. And I'm going to illustrate this in the next slide. This is the story of a young woman who hated PKU. I'd known her since she was 4 or 5, when she was a very pretty, well cared for, extremely shy little girl. And by the time she was a young adult, She'd become quite angry. She had withdrawn from friends. She was rebelling and was not following treatment at all. And because she wasn't following treatment, she wasn't doing as well. She hated her job and she was criticized during her job. So things were not going well for her at all. So she came to see me for therapy. And after talking to her a bit, and she didn't want to talk about too many things. So I went kind of back to the beginning and said, here's somebody who thinks everything has to do with her PKU and she hates it. Whenever she was in a bad mood, her mom would say, what's your blood level? Or if she didn't do well in school, well, of course, because you haven't been sticking to your diet. So she didn't feel validated in any other way. So I started with, what's your favorite color? And she said red. And so I asked her why. And she said, because red is fiery and it's bright. And I said, I wonder if underneath you're kind of a fiery and bright person, even though right now you're withdrawn and kind of quiet. And she smiled. And then I asked her what was her favorite music. And very surprising to me, she said, I think she said it was gospel music. And I didn't expect that at all because she was so rebellious and she wasn't relating in that kind of way at all. And I said, why? And she said, because it reminds me of my father. And her father had passed away a couple of years earlier. And I said, so I think you're somebody who really cares about family and you're really suffering with the loss of your dad and don't have a good way to express that. And again, she looked at me and said, yeah, and you noticed I didn't mention PKU once in any of those issues. And the most important kind of language I was using with her is, so you're the kind of person who, ... and then explained it to help her see an identity. And as we went on, I could talk to her about identity and who is she, and forget about the PKU as who you are. That's just what you eat. And by the end, I have to say right now, she's happily married. She's got a terrific job. She has a little girl and she followed the diet beautifully. And it was a big success story. And the other thing to remember also, though, is that with these new treatments coming around, we're seeing a different kind of population of people. And this article that I refer to here, and there's a reference later, is the most recent PKU article on psychological outcomes. And I found it fascinating because what they found in the adults was those who were continuing on diet and those who had gone off diet completely were feeling most successful in terms of their current life. They had jobs, they had a better quality of life, whereas those who were struggling with diet, were kind of on and off, looked the worst. They had the highest anxiety and the most depression as well. So it was important to think about that in making individual decisions with patients who are struggling as adults. And now these were a group of people who were treated well until they were age 12. So next slide. Here's a couple other points that fit into looking at the whole person, but in a way not. Think about it, that the medications for attention deficit disorder, anxiety, and depression are not effective if metabolic control is poor. So the step one should always be to focus on metabolic control in those who are depressed or anxious before prescribing antidepressants or anti-anxiety medications. And I can't tell you how often the first step is to give them medication and see how it works. And then they keep giving more and more medication and the patients do worse and worse. So beware of the vicious cycle. Poor metabolic control leads to depression, anxiety, and attention deficit disorder, which leads to poor metabolic control. And somebody was once researching why these medications don't work. My guess is that the high phenylalanine levels in some way affect the neurotransmitters so that these medications that are supposed to deal with the neurotransmitters aren't able to work properly. Next slide. Now, here are some ways to instill a sense of identity. In addition to psychologists counseling the patients, parents, dietitians, and doctors can help too. First, allow as much independence as possible, even for children in the beginning. Sometimes this means giving them lots of choices. You can have these 3 choices for breakfast, not this is what you have to have because you have PKU. And then giving them independence that isn't related to diet. Let them choose what they want to wear. Let them go see friends, not be so afraid of those kinds of things. And then establish their favorites, like I did with that young adult that hated PKU. And with ending the sentence, oh, you're the kind of person who. And then this is equally important, giving them opportunities to shine. And this can be at whatever level of functioning they have. I often talk about horizontal development. When I have patients that have significant intellectual or motor deficits, I try to say, well, if they can see, why don't we let them see lots of different things and see how they respond? If they can hear, they can learn lots of different kinds of music and listen to that. So it doesn't have to be an accomplishment of a vertical kind. It can be a horizontal kind, and that helps with an identity also. Next slide. Then we get to transitioning adults and make sure they don't get left behind. What do adults want? They want an apartment, they want sex, and they want a car, mostly. And if they get out of step, that's very difficult. I often say the teenagers need to learn sex gradually. So they become adults and they've been so protected because their parents were afraid that they might eat the wrong food if they went to a party, or they didn't go out with friends because they were embarrassed about their diet or something like that. So they never learned to hold hands, and suddenly they're in their 20s and they're expected to have an intimate relationship. So same with learning to drive. If they've never had a chance to try and back the car into the ditch once or twice, then it becomes a much bigger deal when they're older. Starting at age 12, we always have them meet alone with the health professionals so that they get the sense of, again, independence and identity. And then remember that teenagers and adults scare themselves the most. So it's very important for the doctors and for the parents to set limits and to be very firm, not to change and say, you're an adult now. If you want to damage your brain, go ahead. Some parents get frustrated and say that, or doctors say, oh, if they don't come in, I'm not going to pursue them. Well, it's best to hold them accountable, give them a hard time. And even if they don't respond, they hear you and they know that there's somebody caring and that might pick up the pieces if something happens. So that's important to do. I call it the dance. The job of a teenager to establish, or a young adult to establish independence, is to push the boundaries, to break the rules some. And the job of the adults in that person's life, including their healthcare providers, is to say no and to hold the line, knowing that they're going to break some of the rules. So that's the dance that we have as our young people grow up. And that's true for all kids, not just those with metabolic diseases. And the third key point is that all healthcare providers can help in screening and counseling patients. Psychologists can provide more in-depth evaluations and recommendations for follow-up. So let's keep in mind, what is the purpose of the evaluation in the clinic? First, it's to note which skills are going well and which ones aren't. So that's discrepancies between functions. And then identifying weaknesses before they become serious deficits. Identify strengths to be supported, equally important for self-esteem, and contribute information for diagnostic or treatment decisions. So if someone isn't doing well and it's a disease that should be treated, then maybe, recommend more strict treatment or an adjunct treatment. Provide information how best to communicate with the patient and family. If it's a young adult who has processing problems or slow processing problems or language deficits, maybe written materials work better, or visual materials, or maybe someone else needs to be there and remember it for them so they can go over it later. Next slide. And then sometimes there's research, there's evaluations for research, which are really very different. And these can focus on what is a disease in disorders identified by newborn screening, which ones are mild enough and don't need to be treated, evaluate treatment efficacy, do these treatments work, generate hypotheses regarding neuropathology, what's the relationship between laboratory values and outcomes, increase knowledge of metabolic disorders, and finally, increase knowledge of potential causes of common developmental problems. Who gets ADHD? maybe there's something we can learn from doing research in metabolic disorders. Next slide. So today I'll talk a little bit about some of the tests we use, but I think it's more important to focus on the domains, meaning which aspects of functioning, not the tests. So there's the cognitive domain, a verbal domain, which is the receptive and expressive language. Plus there's a new area that I've become very interested in called verbal discourse. This is language of everyday speech. How well can the person carry on a conversation? Those of you who've treated people with PKU know that sometimes they just can't stick to the topic. I could tell after 5 minutes whether their blood level was high or low based on how well they could focus on the conversation, how well they could use different words, did they keep repeating themselves, that kind of thing. And we're working on a project that just got funded by the National PKU Association to use machine learning to evaluate samples of language to see if that relates to blood phenylalanine levels. Then there's the motor domain, processing domain, executive functioning, behavior, emotional well-being, and quality of life. Next slide. So I'm not going to go through all of this, but I thought it would be useful for you to have for your records. But there are neuropsychological tests, developmental and intelligence tests, plus computerized tests. And these are the ones we use in our clinic for the most part, or for research. These need to be administered by psychologists. The Bailey is the gold standard, as are the Wechsler tests. As the kids get older, we tend to do the abbreviated scale of intelligence rather than the full IQ tests. For those who are very low functioning, sometimes we use the differential ability scale. That's useful. That was useful for some Angelman work we did because it allows you to get a differentiated view of those who are very low functioning. The NIH toolbox I love and the patients love. It's 45 minutes maximum. It gives you something that's very equivalent to an IQ in the total cognition score. The patients don't mind it at all. And then for research purposes, the Cambridge Neuropsychological Test Automated Battery, or CANTAB, is very commonly used. Next slide. There's behavioral questionnaires that we use, and all of these can be administered by non-psychologists. The Vineland is not so good for high functioning people because they do well in it too well. And there's an interview form and a self form and a teacher form. And that's available in Spanish. The Basque is available in Spanish. I like it because it also has an atypicality score, which picks up any autistic spectrum behaviors. The ABAS is a generalized test, interview form or questionnaire that the parents fill out, or there's a self-report form. For adults, they just tend to say everything's fine and doesn't work as well. But for parents to fill out for children, it's quite good. And then the gold standard for screening ADHD is the Diagnostic and Statistical Manual rating scales. Next slide. And then there's quality of life questionnaires. I like to use the NIH Patient Reported Outcome Measurement Information System. This is open sourced online from NIH, if you look under NIH Promise. And the NeuroQL are pretty much the same. And we use depression, anxiety, cognition, and emotional discontrol. There are 8 items in each scale, and they're not pathology oriented. There's now a METAB QOL, metabolic quality of life, that has not yet been very well validated, but looks promising. Next slide. So the screening instruments that are appropriate for administration by non-psychologists, why should you use them? Well, first, they can document need for services. So they can be a first step that says this child needs a full neuropsych evaluation, or this child needs special education, or this child needs speech therapy. They can guide treatment options. If you want to know, is somebody well enough to move on, or well enough to try a new treatment that takes a little bit more coordination of activities. Also to reassure families or validate their concerns. It can serve as a baseline prior to modifications in treatment. It can identify changes in functioning, and it can assess developmental progress. And one of the things that's important to remember is that if children are somewhat delayed, they may look like they're going downhill on standardized tests because they they develop more slowly than their peers. So that's something to pay attention to. And in individual cases, you might want to look at raw scores to make sure that they're moving forward, even if they're standard scores, which are based on the typical developing population, is going down. Next slide. So these are three that I checked that are all in Spanish and easily available. One is the Basque. We talked about that one. Next. The ABAS. And the Vineland, which is the one that's very good for low functioning. And this can be I like to do it as an interview with parents. I get the best results that way. Next slide. And then there are resources for families and individuals with metabolic disorders. There's all the parent associations or the parent-patient support groups, which you might have some that you know of. These are ones that are websites right now, and some of them are programs that are in New England for the most part. Next. So there's the New England Consortium of Metabolic Programs, and these have videos and a transition toolkit. I've gotten requests to translate these into Spanish, but I'm not sure if that's available on this website. But if you're interested, contact me and I can find that information out. Next slide. And you're always welcome to translate these. We always say yes if anybody wants to use them. Same with GEMS, Genetics Education Materials for School Success. That covers far more than metabolic disorders. And this is one of my favorite programs. And even if it's not appropriate, it might be a good model for something that can be done in Latin America. It's for young people ages 16 to 24 living with a metabolic disorder, sickle cell, or other rare genetic diseases. And it's free. Every year before COVID, they had a conference where they could come to this. They had a camp that was wheelchair accessible, and they had nurses and special diets, and anybody could come. But the main issue there was it had nothing to do with your disease. It had to do with your identity. And one of the things they taught them was to speak out. And it was just life changing for the patients that participate. And I spoke with the director, and he doesn't have a translator service specifically, but if there's people who are interested, they can contact nextstepnet.org or me, and I'll put you in touch with them. Next slide. So here are a few of the references that I think you might be interested in. I didn't cover all the ones that you can find on PubMed if you search the various diseases, because I thought it would be more helpful to just hear what 40 years of experience has led to for me, and gave me the freedom to kind of talk about what I've learned through those years. Next slide. So the three key points to remember: that different metabolic disorders lead to different challenges in neuropsychological functioning. Children and adults with metabolic disorders share the need to develop an identity beyond their metabolic disorder, and all healthcare providers can help in screening and in counseling patients. Psychologists can provide more in-depth evaluations and recommendations for follow-up. Next. And there's thank you and a view from Cape Cod, looking over the pond over to Martha's Vineyard in Massachusetts. So thank you very much.
Thank you, Susan, for a fascinating presentation. I really enjoy, like every time I see one of your presentations, this is fascinating. So we have a lot of questions, not much time, so we will try to concentrate questions and try to summarize the public questions. So, well, I don't know, we could be talking the rest of the week with you, but we should start with something. So So hyperphagia, you know, and my hyperphagia used to be a common question, you know, for the families. And the other thing that the topic that you already covered, the early treated PKU phenotype, no?
Mm-hmm.
So and regarding the difference that they could have with the normal population, with the schoolmates and everything else. So how do you explain to the families, you know, what to expect in a patient with an early treat phenotype PKU or with a mild hyperphagia regarding the difference that they could have? You showed us the numbers, but I would like to know, in your large experience, you know, how do you explain to the family about expectation? How do you drive that? You know, how do you drive the family expectation regarding my child will be really normal? Those differences that you show are really important in the daily life. How do you drive that, the family expectation regarding my hyperphagia early treated PKU phenotype?
Yeah. Well, the treated mild hyperphagia or untreated mild hyperphagia? They don't need both. They don't need treatment, then I just say probably will be similar to your other children, or they probably won't have any effect. For those with treated PKU, I try to give two messages to the parents. Number one, that all kids have something if you wait long enough. You got to know what your kid has right away, so we can do something about it, which is really very positive. And because you know that, and you know that they, you know, in the long run, they may have a little more struggle in arithmetic, then as soon as they start to have trouble, you get them some extra help, you know, so it gives you the tools to address the issues, the challenges that might be there. The second message is it's key to develop an identity beyond their PKU. So from an early start, and then that list of things I say, make sure they get to have plenty of choices, and we'll be following them to make sure things go okay. And that there will be some challenges, but there's always challenges when you raise children. So I try to normalize it, is basically what I try to do.
Thank you. And regarding that, Susan, because you repeated many times, you know, that you have to develop an identity besides, you know, beyond the PKU. So you have seen many patients with not just with metabolic disorders, mainly with metabolic disorder, but all of them with rare disease. So how is to live with a rare disease, and how do you because you have long discussion with the patient, I've been witness of that. So how do you afford that? You know, that how is to live with a rare disease? So to be rare, to be special, to be different. How is that in your experience?
Yeah, well, my experience is that the parents report that the disorder has a bigger influence on the lives of the child than the child does. Anytime there's studies looking at quality of life or impact of a metabolic disease, and you have a child response and you have a parent form of it, the children do not differ from their peers, whereas the parents do. So I think that's a good to remember, that they don't often experience it that way. And then in adulthood, like the young woman that I was talking about, she did complain about that. So, and to recognize that I'm not diminishing how hard it is. It is hard. And I validate that with the family too, that this is hard. And the other message I give is, this is going to change you and your family, but it doesn't have to change you for the worse. And I try to point out some of the opportunities that come if you have a metabolic disorder and participate in some of the support groups. Or we had a fascinating time once where we had partners and young women with PK. It was a maternal PKU camp. And we had the partners there, and we asked them to list the pros and cons of having PKU. And the women kind of wrote, well, I can't think of too many pros, but the cons are I can't eat everything and all that. And the spouses had a huge list of the pros, that they're more tolerant of other people. They're accepting of my issues that I might have. They know a lot about nutrition. They eat healthier than I would eat. So it was very interesting. So that's another message I give to families, that there are, you know, it's not all bad, I mean, you don't wish you had it, but it doesn't have to be so negative.
Thank you, Susan. Something that I think is interesting, very interesting to discuss, and we are talking about Latin America. And in Latin America, you know that we are not the same, not just in the cultural aspects, but social aspect, demographic aspect. So, and you have experience in a very special place because Boston has a lot of immigration, and almost 25% of the population speaks Spanish. And you have the opportunity in your experience, you know, to see patients from Salvador, from Guatemala, from Colombia, from Chile, from all over. So a simple but complex question. It is the same to evaluate a patient coming from Colombia, from Chile, or from Argentina? Do we have do we need to have a special consideration regarding different cultural aspects? So the question is interculturality in neuropsychological evaluation. That there are some concerns that you could have?
Yes, but I might not be the most knowledgeable of that since I don't speak Spanish, unfortunately.
You do.
Yeah, a little bit. but I think, you know, this is where it's really important to ask the family, you know, what, especially if they're in our country, what's different, and to get a sense from at least if it's from different from where you're living. For psychologists or healthcare providers in speaking in their own country, in their own language, I don't think a lot of the things that I've said would be that different, except maybe, you know, when children leave the home might be a little different, or how close grandparents are. You know, here we're so spread out that the family is really often just the nuclear family, and grandparents and cousins and siblings live far away. So that can be a big difference. And there I think it would be important to include the whole family in information sessions and in having the same philosophy about the disease.
Yeah, I think that's very important. You know, and something that happens a lot now in Latin America, we have new immigration waves between Latin American countries. So, for example, in Chile, we started seeing more and more patients coming from Peru, Venezuela, Colombia, Haiti, including Haiti. So Haiti is one of the few countries where they don't speak Spanish. So we have the intercultural aspect, not just the cultural, but the language barrier. So I think that's a topic that for Latin America is becoming very, very, very important to be aware about those differences. So anyway, so regarding there is one question from somebody from the public, and regarding the unique perspective that you mentioned. So besides the age, are there any other criteria to consider to identify the most suitable questionnaire for the patient?
I mean, other than IQ for choosing that, they all have a different purpose. So it might be useful to have a little idea of what's the question.
Okay.
And if the question is behavioral, then you would move more toward the BAS. If the question is development, you might do more toward the Vineland or the ABAS if they're higher functioning. If it's, I think those would be the main thing is what's the question.
Okay.
Yeah, if you can only do one, you can do both. That's nice too. Yeah.
Yeah. Well, let me go back to the PKU because of course it's the most common condition that we see in Latin America because the largest condition is screening. So I know you have papers about that. So what is more important, the mean level, the average levels, or the variability levels? So do you mention something about that?
Yeah.
For the outcome.
Yeah, we wrote the paper about variability of levels and we found that the variability correlated better with eventual IQ than the mean level within reason. Okay, within reason. I mean, if someone was very poorly treated, then that trumped it at all. And then actually Sean Christ from Missouri looked at MRIs in patients with PKU, and he found the same thing. And interestingly, they found the same thing in maternal PKU, looking at offspring. So variability, and if you think about it, of course it makes a difference. If someone is, drunk part of the day and not other parts of the day, or one day is feeling foggy and the other day is feeling fine, that's very disconcerting than always feeling maybe just a little bit foggy, So it makes sense to me.
Excellent. And regarding with PKU, you mentioned in one or two slides the ADHD, which is a very common question for the neurologists working in the field. So and of course there are some papers trying to address that issue. But what is your impression? There is maybe that we are overdiagnosing ADHD in PKU patients because the neuropsychological profile. And you mentioned that the treatment is not working like in the real ADHD, or is that real that patient with PKU has more ADHD? What is your impression besides the clinical data?
Well, I think it looks like ADHD, and in the studies looking at pegvaliase, they found that inattention was the primary marker for improvement in it, that the patient self-reported being able to read a book, concentrate longer, that kind of thing. So I think there is an issue of intention. The hyperactivity part, I think, is more related to blood phenylalanine when they're younger, if they get kind of hyper or whatever. But in terms of learning, I think the underlying processes aren't ADHD. I think it's memory, concentration, focus, that kind of stuff. Okay.
So there is a very, actual question regarding the pandemic and telemedicine. Some countries in Chile, for example, we have to move at some point of the pandemic all the consults to telemedicine. So and the neuropsychological evaluation was something difficult to address, and through the telemedicine. So there are some questionnaires, test evaluations that are validated, for patients with telemedicine and metabolic disease. Have you used some? Do you recommend some?
Yes, we just finished a study where we did it. It was middle of COVID. We did it all in telemedicine. So there's different ways to do it, but the Vineland has been validated for that. I think most of the Pearson company questionnaires have been. The self-report, like the PROMIS questionnaires, that can very easily be completed that way. And then we even did the processing speed on the Wechsler tests, which the psychologists can do, because we sent the paper to them, told them not to open the package till we were evaluating them. They opened the package. I set my timer. I watched them do it. I after 2 minutes, I stopped it, and then they sent it back to me. It worked. So, and there's people validating that right and left right now. So that's the way that the field's moving in that direction. In fact, the field is moving so fast in that direction that pretty soon they may not need neuropsychologists, that everybody will do it online. So, and then through Zoom, you can certainly talk to people, and they're used to it now. In the beginning, it was kind of uncomfortable, but after 2 years of school online, most kids can do it and parents can do it.
Definitely. Well, very, very, very good, answer. Thank you. And, I know it is impossible to cover every condition, so I have to ask about a couple of conditions that you didn't cover on the talk. Especially, I have, 2 conditions that I have to ask. One is MSUD, because I know that how special it is from the neuropsychological evaluation. And the other one is GA1, glutamic acidemia, for how to evaluate those patients with, especially the one with extrapyramidal symptoms, where it's difficult to evaluate those patients. So a couple of words with about MSUD, a couple of words about GA1, if you can give us some clues on the evaluation of those patients.
Yeah. Well, MSUD, if treated, seems to be very, very treatable, and leading to very productive lives. The patients that I've followed, though, have had some depression, so that might be associated with that. And then a lot of them are getting transplanted early in our clinic, so for them. So was, and how much damage might have occurred early on. But a point I forgot to make that I think comes up with MSUD is that it's never too late with PKU or any of the diseases. And especially if there was, my experience is if there've been one hyperammonemic episode or one, terrible episode early on, but no others, then the brain is resilient enough to make to recover. And with good treatment and follow-up, those kids do fine. The problem is if they've had an early hit, they often get other hits. But if that can be prevented, those kids do fine, and not to give up. And the same thing after in MSUD and other diseases, after a hyperammonemic episode, they can look terrible. And I was with a neurologist once who it was a urea cycle case, but similar to other diseases, saying this child's going to need a wheelchair the rest of their lives, and they're going to da-da-da. And I was crying, and the parents were crying, and she recovered because it's different. That's what we say, the unique perspective on that. For GA1, what I found there is that there's a spark in those kids. They're far more intelligent than you'd ever expect. And so there's where horizontal development is so important. They can hear, they have good receptive skills. Just treat them as if everything you're telling them they understand, they're learning, even if they can never show it to you, they're being stimulated, and they are understanding. And you can tell with those kids, they'll smile, they'll, ask for more, they'll let you know, much more so than other children who really are so motorically affected. So.
Thank you very much. And then there is one question regarding other conditions. Galactosemia Duarte variant, do you have to follow them neuropsychologically or not?
That's a big debate. I do. Yeah, we found, and Dr. Berry agrees with me, Jerry Berry, who's a big expert in that certain Duartes, and he's starting to figure out which genes might be connected to it. Like 2 Duarte variants can lead to a mild language delay, which gets better as they get older. That's what we found in our study. Judith Friedovich Kyle totally disagrees with me. So there's debate in the literature. Somebody may want to research it. Some states aren't even screening for, or some countries aren't screening for Duarte anymore, or reporting it, because they don't think it has any impact. Treatment doesn't. I mean, it doesn't matter if they had milk or not. So I don't know. We follow everybody, but that's because I was a psychologist there and could, So if you have limited resources, that's probably one you could let go, let the parents know that there might be a language delay, and if so, get some help.
Okay, Susan. So we have just 2 minutes left. So we really want to appreciate your time, your expertise, your knowledge. For me, it has been fascinating, not just to hear, but to have the chance to talk with you. Every conversation that we have, you don't know how I enjoy. So I think everybody enjoyed today, and so we have been very lucky to have you. 1 hour just for us. So
so thank you.
Thank you, really, thank you very much. And with this, we finish this activity, and we leave Florencia to close the session. So thank you very much, Susan.
Thank you.
Les agradecemos su participación y los dejamos invitados a inscribirse en el diplomado titulado Diagnóstico y Tratamiento de Errores Innatos del Metabolismo, desarrollado por el Laboratorio de Genética y Enfermedades Metabólicas de nuestra institución, el cual comienza el 8 de agosto y es 100% online. Ya están abiertas las inscripciones y para mayor información pueden consultar en nuestra página web. Además, los dejamos invitados para el próximo seminario web que se realizará el día 31 de agosto a las 16 horas, horario de Chile, titulado Avances en Eficiencias del Transportador GLUT1, 33 años de ideas y errores, a cargo del gran doctor Juan Pascual. Muchas gracias, nos vemos la próxima.